Thank you so much for having Kathy and I'll start off and then hand over to Kathy. So today we'll be talking a bit about an innovative platform for sharing and accessing Alzheimer's disease clinical trial data. We'll be talking about two specific case studies. I'll be starting with an introduction to Vivli, just very briefly, and how to access data from our platform, a very short case study on a systematic review, and then Dr. Welsh Bohmer will be talking about the Tomorrow study. So Vivli, we are a nonprofit organization, offer convening for a number of different stakeholders. Our main mission is to lower the barriers to access and share data, specifically clinical trial data, and we oversee the implementation of a platform which is for data sharing and computing. Our current industry members are shown here, all of which have made a commitment to sharing data, many of whom have clinical trial data that is in the Alzheimer's disease space or dementia. And I'll show you which trials are available in just a moment. We not only have industry members that have committed to sharing their clinical trial data, but we also have academic and foundation members who also are sharing their data through Vivli. So many of these are, for example, members of NIH, or, for example, foundations such as the Bill and Melinda Gates Foundation. When you look at a snapshot of our most frequently searched terms, you can see that Alzheimer's disease is one of our most searched terms on our platform. So currently, if you do a search on our platform, we have 64 Alzheimer's disease trials. That's phase 1 through 3. If you go on the platform, you can use the refiners, such as by phase, by sponsor, sample size, or by location. So what is included in a study data package? So it's not only the individual participant level data, so that's the row level data from a clinical trial that is anonymized, but also included is the study protocol, the data dictionary that describes the data in the that comes with the data set, the statistical analysis plan, and the guidance for anonymization. Oftentimes the CRFs, so the case report forms, also come alongside, as well as a CSR. So what is involved with actually accessing data from Vivli? So first, one conducts a search from the platform for information about available studies, preparing a proposal that is reviewed according to the contributors' publicly stated requirements, accessing the data. So in a secure research environment, some of the data can be downloadable upon permission. And then accessing that data, we provide robust analytical tools to combine and access data. So those data can be combined with our statistical tools. And then we request that once you access the data, that is also, we ask you to publish your findings, and then those research results are assigned a digital object identifier. So that's really the cycle from search all the way through dissemination. So just to show you what that actually looks like, so you could be sitting in your in front of your computer and combining data, for example, from an NIH platform, from pharma, for example, Johnson & Johnson, GSK, and other platforms as well. We provide all the statistical tools, for example, SAS, R, Stata, Python, such that the data can be analyzed. Our researchers also have the ability to bring in their own data sets. So if you have your own Alzheimer's data set, that can be combined in along with statistical software and scripts into the platform, and that often is the case. So I'm just going to give you a very short case study. This is not my own data, but one that was presented at one of our annual meetings out of Dr. Sharon Strauss's group. And this happens to be a systematic review using data from the Vivli platform. So again, this is not my own data, but just an example of what can be done by accessing data from Vivli. So again, the aim here was to look at comparative effectiveness and safety of cognitive enhancers for different patient characteristics. So these were some of the drugs that were compared, looking at both individual participant level data and aggregate data. So not all of the studies were available. The IPD, or individual participant level data, was not available for all of the studies. So they used aggregate data for some of the comparisons. 80 RCTs were compared, so 55 industry-sponsored studies. So 9 publicly sponsored studies, 16, there were no information on the funder, 6 industry sponsors responded, and then 14 RCTs were represented. So about 8,000 participants were represented in this systematic review. So shown here are really the conclusions, and that the mean difference of all cognitive enhancing regimens except for single agent oral drugs were clinically important for cognition, but you can see that they were able to find some meaningful differences here in terms of the systematic review, just from IPD analysis, and they were able to publish on their findings from the systematic review. And that's really what I wanted to show you. And we do have several papers on Alzheimer's disease that came out of IPD analysis. So next I want to hand it over to Dr. Welsh Bohmer for her presentation on the Tomorrow study that is also can be accessed on Vivli. So I'll turn it over to Kathy now.
So I'll be presenting the Tomorrow data, which actually has its genesis right here at Duke University, started about 12 years ago, and is now, as Rebecca was saying, is now situated on the Vivli platform. It's been a really great discussion here over the last couple of days. I'm really excited about what the opportunities are to really start to mine the Tomorrow data, particularly as we try to look at what's a clinically meaningful change that's occurring in the very early stages of Alzheimer's disease. I think we have to think differently about what is a meaningful change in a disease modifying context of when you're treating Alzheimer's disease, with the idea that you're going to modify the course of the disease versus a symptomatic improvement where you think you might see a small change over a shorter period of time. When you're talking about disease modification, we might have to rethink what our endpoints are, and we might have to rethink our statistical models when we're looking at change that might be occurring over a very long period of time. In 12 to 18 months, that change may be very small, but it's really more cumulative over a longer interval that I think is going to become important. First, my disclosures. I'm funded to do work right now to improve the usability of the Tomorrow dataset for researchers through a grant for the National Philanthropic Trust and the Alzheimer's Disease Data Initiative. I also get some funding and do some consulting with pharma companies, as you can see listed here. Over 10 years ago, there was a new generation of Alzheimer's disease trials that started, and these were secondary prevention studies, as you can see listed here. There are now other studies that are entering into the field that are prevention studies like this. I list the 4 main ones, the 4 main programs that started in 2013. They include the Dominantly Inherited Alzheimer's Disease Network, or DIAN-2 studies, the Alzheimer's Prevention Initiative, or API studies, the Alzheimer's Disease Cooperative Study, or A4, and subsequent studies in that portfolio, and then our own Tomorrow study. And you're probably saying, is that a misspelling of Tomorrow? Don't you spell it with 1 M? And that's actually sort of a play on words here. The Tomorrow study is looking, all of these studies, what they share in common is that they have a study population that's enriched for developing Alzheimer's disease over a short period of observation, 5 years. And all of the participants in all of these studies are starting off as clinically normal, so not having any cognitive disorders, but enriched to develop cognitive disorders based on some risk factor. The three that you see in purple now on the slide are all studies that are looking at amyloid lowering compounds. And they enrich basically on two of these studies are enriching on the basis of genetics. So the Diane study, the dominantly inherited study, is enriching based on genetic mutations that confer a high risk of developing amyloid abnormalities. That's the same rationale for the API study. And for the A4 study, individuals get into A4 because they are already showing abnormal aggregation of amyloid on PET imaging studies. The Tomorrow study is different in that the Tomorrow study is using a polygenic risk score, genetic algorithm, in order to determine a group of individuals that are at higher risk. That algorithm is based on some genes that you heard about yesterday. And one of the discussions is ApoE, TOM40 genotype, and age. So the combination of those three variables determine whether or not an individual is in a high risk group or a low risk group. The other difference between the three previous studies that I mentioned and the Tomorrow study is that the Tomorrow study is designed, the compound that's being tested is not designed to lower amyloid, although it may have that impact. It's really designed around a small molecule, pioglitazone, which is a compound usually used to treat diabetes. It's a low dose of that drug. And at low dose, it's been shown to have a mitochondrial function and an effect on metabolism. So a very different mechanism of action that we're looking at. This gives you a little idea behind the strategy for risk enhancement within the study. These are basically survival curves. You've probably seen these before with ApoE. And what you'll see here is that the red curve, green, and kind of a blue-purple curve here correspond to ApoE genotype. And these are survival curves that you're probably all familiar with, that if you inherit 2 copies of your homozygous for E4, higher risk of developing cognitive disorder over time compared to somebody who only has 1 copy of the allele compared to 3-3 homozygote. So those are common curves that we're familiar with. What happens with consideration of the TOM40 genotype is you get a broader coverage, hypothetically, this is a hypothesis, a higher coverage of risk relationship between development of Alzheimer's disease if you know both the TOM40 genotype and the ApoE genotype. So the rationale for this is listed here. Turn this one on. Is this working? Yeah, this is working. So this is using a polygenic risk approach to enrich the study population, combining the 3 variables that I said, and we get about 97% coverage of information about individual risk for developing disease. And this is just a quick overview of the study. So the study was designed to be a multi-center. There's essentially 60 sites that started in the study. We ended with 57, testing a low dose of pioglitazone in about 3,500 individuals. Primarily, this is a point I'll get back to relevant to the discussion here today. Is primarily a white population that participated in this trial, which is a problem with many of the Alzheimer's disease trials that we've heard mentioned before. And the treatment duration was 5 years. So this is a long trial. Again, we're working with people who are asymptomatic, so we have to observe them longer in order to see whether or not there's a treatment effect. And that was the time period that was estimated to be of the duration to have the necessary events that the study was powered to see 202 primary endpoint events. So what is the primary endpoint? The primary endpoint in this trial is not cognitive change like you would normally see in a clinical trial. It's time to event. It's time to the MCI due to AD diagnosis. So that's another difference between this trial and more conventional clinical trials in Alzheimer's disease. This infographic gives you an idea of the study design. And what you see here is actually there are 2 co-primary questions that are, or 2 co-primary aims in this study. the study is designed not only to test whether a compound is having an effect in slowing the disease, it's also designed to test that genetic algorithm that I mentioned at the start and whether or not it can be validated as predicting those that are more at risk for developing the endpoint MCI due to AD over 5 years. So it's testing 2 different hypotheses. How do we do that? We basically have a starting population here. There are going to be more people that were selected and enrolled in the study who are at high risk. So that's why you see a bigger population right here of high risk. There's also a smaller group of people who are low risk. Since these are all healthy people who do not have a disease, who may or may not develop the disease over the course of the study, we have to be very careful when we start giving compounds to people who don't have a disease yet. So only the high risk group is the group that's going to be randomized to compound. We would not be putting people who are at low risk on a compound that may have some safety concerns. So here you have our high risk group. They're randomized either to placebo or to treatment and followed over 5 years. The prediction here is that if the compound is working, you'll have fewer cases at 5 years compared to the placebo group where you see more people affected. Now in this arm here, we have a low risk group and we have a high risk group. They're both getting placebo. And this is allowing us to test whether or not the risk algorithm predicts who's going on to develop disease. So again, the prediction here would be that if the high risk group, the algorithm that was used to group people here predicts disease, we'll have more people here at 5 years who are high risk compared to low risk. So it's testing 2 different questions in the same design. And I know I've got short time here, so I'll go quickly. This is just telling you what the endpoint is, and I think you'll get the slides. This is how we mapped the MCI due to AD diagnosis, because we have 60 sites. We have to make sure everybody's doing it the same way. These are the measures. It's a complete neuropsychological evaluation that was done every 6 months with participants. And you can see these are not your traditional endpoints, but they actually are more like the endpoints we use in clinic to diagnose patients. And that was because the diagnosis was the endpoint for the study MCI due to AD was a clinical diagnosis. This is just showing you the overall time frame. Study started in 2013. The effect size was changed about 2 years into the study. So they, Takeda, the sponsor, felt that the effect that we would observe would be larger, so that we would see basically a 40% reduction in the number of cases of MCI with treatment. So now it's a higher bar that's being set 2 years into the trial. They went to futility analysis in 2018, and the data did not look like we would be successful in meeting that endpoint. And so the study was stopped prematurely a year before it was intended to stop. So let me just quickly show you what we found, because I think it's really exciting. And this is basically, I'm just going to give you the final word here, which is, this is an advertisement for the data set. I'm trying to encourage you to go use the data. Okay. So we did have converters in all 3 arms, as you can see here. We had a total of 96 converters here, exposed over a period of 32 months, essentially. Here are the data. As would be expected, the low group was actually significantly younger than the high-risk group. The lowest group was significantly younger, and that we would have predicted because the algorithm was based on age, ApoE genotype, and Tom40 genotype. So we would have predicted that there would be a difference there. This is concerning. This is what I mentioned at the outset. There are very few individuals who identify as either Black, African American, or in our other minority groups, as you can see here. So it's under 5% that we're seeing identified. And this is not unique to the Tomorrow study, as I'll show you in a moment. So what did we find with the biomarker risk algorithm? So if you look here, you can see that as predicted, the high risk was indicating that individuals are more likely to develop the event of MCI due to AD. You can see the adjusted risk ratio right here of 3.26. And the P level is significant. Unfortunately, we had set the P level for this study to be at 0.01, so this was considered to fail. But I think many of us would argue that that's not too shabby. And here you can actually see the Kaplan-Meier plot, so you can see, as predicted, the high risk biomarker is predicting those that go on to develop the endpoint of NCI. Again, the study was truncated a year early, so that's why I tend to be more optimistic about the data I just showed you, because it was truncated. We would expect more events had the study continued for the additional year. Did the compound work? The short answer to this is no, but again, you can see it's in the predicted direction. So showing that exposure to pioglitazone looked like it was being somewhat protective. And you can see here the Kaplan-Meier curves again in the direction that we had predicted, but not significant. So it was terminated early prior to completion, and data is showing non-significant trends. The data are available on the Vivli platform, so this is one of the ones that are available there. It's a rich data set, longitudinal data with clinical phenotypes that are quite unique. And so I think it's very helpful when we're trying to begin to look for signals of what's happening in preclinical disease. We have a copy of the data set here at Duke and are working to improve the documentation as well as some of the scripts to help people calculate common variables in the data set. So we're working with that in the protected environment of the ADDI, which is also a platform that interacts with the Vivli platform. The weaknesses, as I pointed out with the Tomorrow data set, are in the representation of the cohort. And as I mentioned, this is not unique to the Tomorrow data. This has been seen across clinical trials. So we see that 2/3 of the population and in prevalence are women. We also that are affected by Alzheimer's disease. We see older Black and Hispanics also being more differentially affected, and yet we see that these different ethno-racial groups are less likely to participate for reasons that we all recognize are complex and have been discussed here. We're very hopeful that that situation is now rapidly changing with the FDA requirement that all companies have a diversity plan in place before they start their work, or risk the potential of being told that they have to do another trial because their population was not representing the population affected by these conditions. And we heard about the genetics and why this is important yesterday, that we have a better understanding. I think I wanted just to close and say that I think while the numbers are small in the Tomorrow data, and that's egregious in terms of diversity, and while that situation is the history we see with other Alzheimer's disease trials, I think that there is the potential for combining data across different data sets to begin to look for signals. And so that's what I would encourage us to do, is to begin to look across these different data sets that are situated in platforms like Vivli and the ADDI. We're working to enhance this right now. I won't go through that, but here you can see that on the ADDI workbench, if you were just to Google that and look at it, there are 49 AD data sets that are there. This is established through the Gates Group and the National Philanthropic Trust. Again, data sets like EPAD, PREVENT, a lot of other data sets are there that would allow you to combine data and look for signals. And then, of course, we have over 60 data sets on the Vivli platform that are Alzheimer's disease data sets, as well, as Rebecca pointed out. We have the data here at Duke. I welcome collaborations. I'd love to hear what people's experience is on the platform as they try to link Tomorrow data with other data that are either on the ADDI platform or the Vivli platform. So thank you for your time. Yes.
Why was the bar initially set at much higher as opposed to 1.5?
Why did they change the cut size?
0.1, yeah.
That's a good question, and I think, and we get asked that quite a bit. I think the frank answer, I can't possibly know what Takeda was thinking because I'm not working for Takeda. But what I can say is prevention trials are incredibly expensive to run. And I think that it could have come down to a business decision that because you're studying huge numbers of people over 5 years. And the prior probability of a study being successful or failing in the Alzheimer's space, 95% at least, or failure. So I think from a business perspective, that may have been part of it. it was driven by data. They did have data that they looked at to make that decision, but I think it's complicated. I think it involves data as well as like, what's the risk benefit ratio and the business.
But you're right in the model, rather than studying patients with early AD, mild AD from 50 centers around the world, people who are, they sort of genetic risk and see who will convert to that.
Yeah, I think that's really the direction that we're moving in, is taking these different polygenic risk scores or other approaches and then using that using either the biomarkers or the polygenic risk scores to see how much change you could predict over time, and using it to power your studies so that you can have a shorter time frame of observations. I think that's the direction we're moving in now.
Thank you so much for your talk. I have a question about the drug that was used in the Tomorrow study. You said it affected mitochondrial function. I assume in a positive way, since Tom-4 is dysfunctional. Was there a way to assess mitochondrial in the participants in the high risk group who got the drug to see if it was actually having an impact on that?
So it's a great question. The answer is no, they didn't. But the drug that was selected, piclidazone, as I was saying before, it's used commonly in diabetes. It's used at a much higher dose. It's about 15 to 30 milligrams typically what's prescribed, and this is 0.8, so it's quite a bit smaller. The reason that, and they did show mitochondrial activity at that level. The drug has a broad effect on a variety of different targets. It does affect amyloid. It does affect some of the other targets, but its primary mechanism of action, its belief, is the mitochondria. They did collect blood samples, so one would think it's possible to look at that. But I'm pretty sure that the blood samples have been used. So we weren't required to do the traditional biomarkers that are now being done, A-beta and tau, because this was over 10 years ago when the study started. But they've now looked at plasma A-beta and plasma tau and GFAP and NFL, and I believe all the samples are now depleted when they did those analyses. So, unfortunately,
Thank you.
Thank you.